So the issue is the creation of optimal dental ceramics, ceramic aesthetics. And we're going to talk about the options, different ways of doing it, the limitations of each, as Coney did, and the solutions we've found. And I've taken a slightly different tack, and I'm going to talk predominantly about pink. Whereas we all think about ceramics as white, I'm going to talk about pink ceramics as a very key component of the white. Because when you really look at it, ceramic aesthetics, it's really not all about the white. Because when you look at the white, the individual shapes of these singular teeth in the upper half, it's undoubtedly predicated upon the pink. And you can see even tiny little slivers of the bottom half of the papillae dramatically impact the form, the shape of these teeth. And when we think we've got a papilla, but not the complete expression of that papilla, we just don't have it. We don't have it available to us. So the pink is critical to all of this. So we're going to talk about, if we really want to mimic nature, you have to understand the critical interfaces, and we'll talk about the 4 different interfaces. So when you look at it, there are 4 interfaces that we have to deal with as dentists. And when you look at these 4 interfaces, they come, the first between the face and the lips, how they come together, where the lips are relative to the face. The second, where the gingiva is relative to the lips. Think about a high smile, a low smile line. Then the teeth to the gingiva. How do the teeth get affected by the shape of the gingiva or missing parts of the gingiva, like papillae? And then we're going to talk about something completely different, new. And this is the last interface, the pink-to-pink interface. It's a new idea, it's a new concept, and very critical to what we do. So the first one is really gums to teeth. You see how these little pieces of tissue, even though this patient doesn't have a high smile line, remember that over 80% of your patients show some gum when smiling. It's not a high smile that's critical, it's some gum when smiling, because these little pieces of gum in an almost low smile really impact the silhouette form of these teeth dramatically. And then we're going to talk about the relationship between the gingiva and the lips, a pink-to-pink relationship that's so crucial. Where do we want this interface to be developed? We talk very glibly about aesthetics. We look at aesthetics and we go, that's pretty good for an implant. The answer is, it's pretty good and non-discernible, and you shouldn't know it from a natural tooth, or it's not good. The question becomes, how good? So how do we actually evaluate dental aesthetics? Is it a science, or is it just an art form? If we're going to teach it, it needs to be a science. So we need to measure and record definitively. You've got 3 implants next to each other, they look pretty good. But you actually have to go through the process of measuring where the zenith is, how long the papilla between 2 adjacent implants is, and then you really need to compare this against the base norm. On the opposite side, we happen to have 3 different teeth, periodontally involved, so even worse as a measure. And now we have 6 individual crowns across. When you look at them, you'll see 3 teeth and 3 implants. And if you start to actually look at it and start to draw lines, you will see that the tooth-to-tooth relationships, the papillae are normal, the implant-to-implant relationships, they're quite different. The tooth-to-implant relationship still remains normal. So the presence of teeth is an incredibly crucial part of making teeth normal, or making the restoratives normal. Remember the difference between a tooth-to-tooth relationship or tooth-to-implant relationship in the height of the papilla versus an implant-to-implant is about 2 millimeters. That's about 40%. It's a big difference. It changes the form of teeth very dramatically. So when we evaluate aesthetics, we need to get real numbers, decent numbers, and try and evaluate it. In everything else we do in science, we have numbers that look like this. We can't look at them, we can't evaluate them, but just get a feel for some of them. We're talking about, regeneration of crestal bone, and we're talking about 0.2, 0.3 millimeters. Surely we can do this with ceramics. I mean, let's get some real numbers. Otherwise, don't say, saw Coney today, he was really good. I want to know how good he was. I want to know how good the procedure he told you was for any given situation. And is it better than Marcelo's, who's showing you as pretty procedures, but doing it differently? Which one's more predictable? You need to know this information for your day-to-day practices. So when we talk about evaluating dental aesthetics, understand there are two distinct components. There's white aesthetics, and Nurse Belser did a great job of defining this, and I'm not going to deal with this. Kenny will do, Rob Winter will do with it. And I'm going to concentrate on what we call the pink aesthetic score. And this is from Furhauser. We're going to talk about how the pink needs to be if it's going to affect the white correctly. And when you look at this carefully and you outline the form of a tooth, you realize that the upper half of this tooth is totally defined by the pink. So this portion of the tooth is pink defined, and that's a crucial component. We can't lose it. So when we look at white aesthetics, it's all about the pink. Let's talk briefly about white aesthetics. I'll show you one case because I'm not going to really dwell on it. We're talking about class 1 gingiva, means the gingiva has no way been compromised. We're going to talk about pre-existing teeth, and as Coney showed you, they can be mildly compromised. They can be a little more severely compromised, requiring a crown. They can be quite severely compromised, as Coney talked about, and then we've got to make a decision first on how best to restore the integrity of the tooth, and then the restoration. But in all of these, you see, the gingiva is perfectly normal. It's an easy fix. The pink aesthetic score is a 14. The problems always become when you take teeth out and you have to replace teeth. The moment you take teeth out, we know we have changes, and dentists went into this very effectively yesterday with Otto Zur. So we suddenly have a pontic, and the ridge collapses, and we have to rebuild this pontic as we've been doing for 30 years with some form of tissue or tissue and bone, so that the pink aesthetic score looks exactly the same as the adjacent tooth. And as we've moved into implants, of course, this is yet another story. Can we make implants totally non-discernible from adjacent teeth? We've got all sorts of tools from white aesthetics. Kenny will show you some, Bobby will show you others. There's still confusion on what's best. But basically, all we're trying to do with it is get longevity out of it first, and then we're going to try and match the color. Matching color, we know, has several components: value, hue. You mix them all together, you get chroma, and you can match the color with a multitude of different systems pretty effectively. I don't believe white is a problem. So the only problem I have with white is when it's impacted by the pink, when the shape of the pink determines an aberrant form of the white. Like this. It's an older case, it's 17 years old, quite nice porcelain, isn't it? But the case is ugly. I mean, anybody here like the case? It's an implant-supported case. What's the problem with it? I mean, we've got distorted tooth forms in the anterior portion of the mouth, and really because we don't have normal pink architecture. This is the problem. It doesn't matter which dentist you give it to. We give it to Willie Geller, he will play with this ad infinitum, and he will get an equally ugly crown. When you look at it, from Albertson or Danny Boozer's work or Adele's, this is perfectly healthy. It's a highly successful case, but it remains ugly. Ugly is not a good term. So look at it. Not bad, is it really? Quite good ceramics, if you look at it carefully. So we take this case, and this is work done before us by Buerta and Gluckman, and we look at it and we say, let's draw in on this, where the optimal silhouette form of the tooth would be. Because remember, this white is poorly affected by the pink. So we draw onto this where it would normally be, and we etch apical to this, the part above it. We sandblast it and we etch. We add a little flowable composite that I learned from Marcelo Calamita and from Christian Coachman, and he'll be here tomorrow. And then we put body composite onto this. And then we just do directly in the mouth, and we take this flash off. Putting it back into the mouth, you can see, trying to normalize the tooth form, and you can see the dramatic change in the self-same 17-year-old bridge that was never put back in the oven, done just with composite. You get a sense of how incredibly important these little pieces of pink are. You see, when I say it's all about the pink, look at it, it's all about the pink. And this is what she looks like about 3 years down the road. And when you look, you see this could have been planned better because this pink-to-pink interface, the new interface, is within the aesthetic zone. Where would you like it? Beyond the aesthetic zone, beyond the inferior border of the upper lip. And in all future cases, given the chance, we'll do this in advance. So let's look at different ways of handling cases. Quite an aggressive case. These teeth are all going to have to come out, and the big deal is, can we preserve all that remains? We must do everything we can to preserve all that remains. The alternative is if we don't, we're going to have to reconstruct it. We can reconstruct it obviously surgically, or you can do it with ceramic. We're going to go and see first, do I think in this particular case we can preserve it all? You look at the case and you realize we have some problems. All the teeth have to come out. It's idiopathic external root resorption, and anybody thought about getting them out? I mean, as you grab hold of this tooth, it'll fracture, this will fracture, this will fracture. So you have to core them out or take them out without destroying the buccal plate, and we use a piezo to do this. So we're going to get them all out. Remember, she's within the aesthetic zone. We want to keep her looking attractive. Taking all these teeth out, it's incredibly minimally traumatic because we want to keep the type 1 socket, meaning we don't want to impact the buccal plate at all. We take out all the teeth, we put in 8 fixtures, and we've got these 5 teeth left over here to support the provisional during the interim phase. Now we get to this phase, these are integrated, we've got to decide what to do with these teeth as we transition from a tooth-supported to an implant-supported bridge. And what would you best do with those teeth? Knowing that every time you take out a tooth, knowing from Maurizio's work, Araujo and Lindy, that we will have repercussions. Take out a tooth, you will have repercussions. So what's the best alternative? Don't take out the tooth. Just keep the tooth there. So we're going to an implant-supported provisional, and these remaining teeth we're going to keep. We're going to cut them off, We're going to cut them off 1 millimeter above the bone. I'll repeat that for you, 1 millimeter above the bone. We want those supracrestal fibers to tent the tissue and the shape of the coronal aspect of the crown. We do it vital. There's no reason to do it non-vital. And we submerge these teeth. Not a new idea. This is Jerry Bauer's work, as you remember, as a periodontist. Vital roots retain their vitality. Cementum grows above it. No, resorption, ankylosis, or pulp depth. Greater percentage of regeneration of the attachment apparatus when we do it this way. And you can see some of our cases, the actual dentine or bone growing across the top of these cases, maintaining the soft tissue, the pontic areas in perfect form for us so that we can get beautiful final results. The big deal is don't cut down to this level because we want these supracrestal fibers above the bone. These are the fibers that tent the tissue up. Remember, on an implant you have no horizontal fibers, you only have vertical fibers. You want these fibers given your options. This is just histology on it. And as we put it in, look at the soft tissue. As we mold it, impressions, temporary, and we go to the final case. Look at the soft tissue, look at the form, look at the buccal convexity of all of these, and we pop these in to position. This is the article on root submergence we wrote with the group from Japan, the 5D group, Tomoko, and of course, Aki. And this is 5 years later, taking it out and seeing how the soft tissue looks. And of course, being able to maintain this over the long haul. So let's talk a little more about pink aesthetics. To replicate pink aesthetics, if it's lost, we have to understand what it is. So we have two different zones, the papilla and the free gingival margin. And when we look at it, it's this bottom half of the papilla that's so crucial to us, real crucial to us. So if you get a papilla up to this point, it's not a papilla. It's kind of like running a marathon and getting 25 miles. You did damn well, but you haven't completed the marathon. You haven't finished. You don't have an end result yet. So we want to see the correct gingival contour, and you want the full papilla tip, not just a papilla. When we look at this three-dimensional form, there are really four different components. There's the free gingival margin curvature around teeth or implants. Then you can see compromise in a papilla area, one or both. So the disease is very specifically located, and you have to look where it is so you can treat it specifically. And then there are two aspects which we've been talking about for a while, color and shadow around implants, around pontics. How do they impact the naturalness of a tooth? And then we'll talk about ridge convexity. As I just showed you, retaining that ridge convexity is crucial to optimal ceramics. So we're going to show you different ways of handling it. Avoid the surgical ones predominantly because this is a ceramic symposium. And we're going to talk about this last interface now, and that's the pink-to-pink interface. So let's talk first about the pink-to-white restorative interface. You've got teeth, obviously too long, elongated, distorted, aberrant tooth forms. We fix them up by adding pink porcelain to these, and all of a sudden the teeth are really pretty. But in adding this pink to the white, you get a new interface. You get a pink-to-pink interface. So this is the pink-to-white interface. It gives you optimal tooth form, as good as you can get. And now you have a new interface, which we call the pink-to-pink interface, which is up here. And this pink interface, where would you like to see it? The crucial part of this pink interface is you don't want to see it. You don't want to see it because you will never match it very effectively. So where's the best place to put it? Out of the way, up underneath the lip. That means if you have to take away bone to facilitate this, take away the bone. Even if you've grafted bone, even if it's iliac crest, and it's beyond the lip perimeter, it needs to go. It needs to go so that you can develop ceramics that's pretty. So if we get an interface in this area, which, is coronal to the lip perimeter, trying to match the bottom half of this papilla onto this or this, it's not going to work. There's no way I can get a papilla smack in the middle of your face to match the remaining papilla. It's just not going to happen. So a small piece of papilla you don't want to look at making. You're going to make the whole papilla or none of it. So when you do this, you want to move this interface up underneath the lip here, where you see. And you want to move it apical to the inferior border of the upper lip. Get it up out of the way. So here's a kid who's had really some significant trauma. Do we preserve this? Obviously not. It's already complicated. So I've got to reconstruct this. We reconstruct it. First option is surgical. This is a big surgery. She's already had one hip graft. You want to do another on top of a scarred first hip graft and then try and get this tissue good. I mean, what are your chances of getting an 80% result? Not that great. You look at Esposito's work, he talks about in vertical bone augmentation, anything from a 20 to 60% complication rate. 20% in my practice is a big complication rate. 1% is a problem. So we're looking at alternatives in this. She's got type 3 defects. Type 3 defects, from dentists. A type 3 defect means you've lost both vertical and horizontal wall. When you've lost the vertical, it's difficult to reconstruct. We can put in horizontal any day of the week. So this is the young lady. The first thing is let's collect the diagnostic information. We want photos. I want dynamic photos. I want to see the lip go through all its machinations. Where does it go? How does she go in a grimace, in the widest smile? What does she look like when she's demure, when she's just talking at me across the table? I want intraoral models. I want to know just what do you expect, patient. We want to evaluate the remaining dentition as a guideline. We want to look at what bone we have left, what the tissue is like, and we'll go through a CAT scan and 3D simulation on this. Old photographs are obviously very key in this whole process. 4 phases of treatment. The first is the diagnostic wax-up. You can't start putting implants in until you've done this. You can't even contemplate it. You will be in trouble. So the diagnostic wax-up we do this way. Take this, you take an impression, you generate a stone model. We do a wax-up of perfectly white teeth. Who does it? Any lab. Any lab can do it. They can make you white teeth. It's not that difficult. Can you wax me up 4 white teeth? I've been doing this since I started. When you've waxed up the 4 white teeth, backfill it with pink wax. That's all. I'd like you to put it onto a little acrylic base plate for me so I can try your wax into the mouth. It's not that difficult. So we're going to take this outlined in red now, and we put it into her face. It has no relevance on the lab bench. Until you get it into her face, it doesn't mean anything at all. You put it into her face, you pop it in. It's obviously not the right color, but I can see the tooth form. I can see where the pink comes down. I can ask her, Jen, is this what it used to look like? No, the teeth were a little longer. I can add a little wax. She says, you know what, Dr. Garver, I think you made them too long. No sweat, I wipe it off. Let's make a decision. Let's come to terms right here before I pick up a blade on what you want to look like right from the outset. You must have this information, otherwise we can't do it. She finally okays this. She likes it. She likes the tooth form. She likes the amount of papillae that show during big smiles and small smiles, and you'll see she does change. We've made all the changes right now. This is what the final case will look like, but in a more permanent more permanent material, ceramic. We slip it in, we check the usual things, lip line, horizontal and vertical, lip support, the position of the papillae, the morphology, and we get them to sign it off. You like this, Jen. So I now have this diagnostic wax-up. I take that diagnostic wax-up because it's going to give me the ability to visualize three-dimensionally what the final case needs to look like. And it gives me a perception in numbers, in real numbers, how much pink is missing, how much bone is missing, how much soft tissue is missing, how long the teeth should be. Once I've done that, I can utilize this to develop radiographic stents and bone reduction stents. So you take this, you do a vacuum form over it, you put a little barium sulfate on, and you put her into a CAT scan. I also take this and I use a Siltex matrix over it, because this gives me right from the outset a final form for the prosthesis. No lab man is going to have to sit and guess, Garber put the implants in the wrong place, I'm going to try and make them work. I put the implants in, this is what I anticipate you're going to make the teeth look like. You know in advance, don't have to work this out. So we have a diagnostic cascade. You have the wax up, we try it in, we make any changes, and we like it. Based on that, we do a barium sulfate scan, and we put her into a CBCT. From that, we get the images on several things. We all get excited, where's the bone? But I want to see not only where's the bone, how much there is, but I want to see the outline of the tooth form, and I want to see the lip very, very accurately. I also want to know, when you smile, at maximum smile, how far does this lip translate from this incisal edge? How far up can it go? I'll give it to you again. Big smile, a grimace. How far does this inferior border of the lip translate as measured from the incisal edge? I need that information. We can put it onto various types of software. This is Simplant, and from that we get different kinds of surgical guides that we can utilize. So you can see this whole thing is planned very effectively. Simplant really helps us in setting this up. When we first talked about this, you'll see there are 4 quadrants to it. When you look, B is obviously the bone, C is what you see aesthetically, A is the lip, and this whole component here is pink and white, and that's the restoration. Now, when we plan this, this is what you want to know. You want to see the full dynamics of the inferior border of the upper lip. There is nothing static in this. It has to be dynamic. It has to be moving. You have to have endpoints taken. You take that and you add to it the 3D existing morphology of the bone. You add to that the need for lingual screw access. It's essential. You must have lingual screw access. So these are all givens. If you can't have these, don't do it. If you can't pull these, it gives me the implant position and inclination. We want it screw retained, so we're going in this way. Okay. We put the implant in. What do I want to know now? I want to know how far can this lip translate in a wide smile as measured from this incisal edge. And when you look at it and we pick it up, it goes up to there. Assume this is 48 millimeters. When she smiles wide, it goes 48 millimeters, it goes up to there, which means what to you? It means when she smiles, you're going to see this interface. That doesn't really help us. So it means this implant needs to go where? It needs to go up further apically, and you have to get rid of that bone. So this implant needs to go vertically. Remember, this is the angulation, we put it in, but because of the lip, I can see that we're going to see it. I need it to go up vertically. So this is the amount of bone that will be taken off to make this work. This way it will be hidden behind the inferior border of the upper lip. So wax up, try it in, you get your radiographic stents, you get your surgical guides, and you can do it. It's all pre-planned. Second phase, let's look at the surgery. First guide is, where do you want to place the implants? Mesiodistally, buccolingually. Those are the first two. The second gives you kind of your fixture level, how far vertically you want it. Do you want it to go up further underneath the lip? And you can either take away the bone in advance, or you can screw the implant up deep and take away the bone. This is doing it. And you can see we've screwed them in deep, and now we're just taking off the bone to the level as measured from the incisal edge. So you can see we're actually trimming it away just with rongers. And that little piece adjacent to the canine, it needs to go. We measure, it's not deep enough, we screwed it in a little deeper, and we're going to take away the bone to the top of the fixture level. Putting in just little cover screws, and now flattening everything. And you want it how? You want it flat. It must be flat. This is not ovate pontics. This is a flat interface that you want. So you can see we're developing it completely flat. At the time of impression making, you can see I've taken a laser or a rough burr, and I've just flattened it out further. I want no crenulations, little bubbles. I want smooth, contiguous tissue. We take our impressions and we generate a model that has flat tissue. And of course, we've positioned this pink-to-pink interface by pushing the implants vertically beyond the lip perimeter. Other thing is, it's always screw retained. It must be. This is the fourth phase. We've got to make a dentogingival provisional, meaning white and pink provisional. Real easy to make because you tried this in, it looked real good. From that trying, you know what you have to look like, and you generated a vinyl stent right at the beginning, the first visit. You take this, you fill it up with cold cure acrylic, and you put it on top of a model with some analogs on, and this is what you get. These are the tooth forms that you anticipate you're going to get. This is the perfect tooth form. Because we looked at it here, we had it over here. It is the same tooth form. Now all I've got to do is fill in the pink to get the optimal white. So this is cold cure acrylic, this is pink composite that allows it to look like normal tooth form. This is your provisional. Trying it in, it doesn't look real pretty. So what we're going to do at this phase is I just want to ensure the implants are high enough up. And you can see I've even further flattened it because there was some tissue to ensure she can't see it beyond the lip perimeter. And I'll just adjust the occlusion, the incisal guidance, that's it. Now we'll put the papillae tips in. No anesthesia is real key. No anesthesia, smile. I take a little round ball of the right color, and I just pat it in. I say, smile. She looks good. I cure it. I got the papilla exactly where it needs to be for her lip. No one else's lip, her lip. There's nowhere else I can do it better. Nobody can do it better than you. You know the patient. So you put these 3 little papilla tips in, cure them, and then it's really easy. All you've got to do is backfill it until it hits the remaining mucosa that you've just flattened out. and it's real nice. You can't get a better model than this. You just pat it onto the soft tissue. You're going to get a little overlap. You're going to get some flash. We'll cut it away. It doesn't matter up here. We made sure it doesn't matter because it's way up under her nose. May even be in her nose, but it's out of the way. This is just putting the acrylic on. You can see I learned it, from Christian and Guy. It's very, very easy to do, and you just pat it on, and it works incredibly easily. So you can use different colors. You can see putting a little red on, and then it doesn't match. You put a little lighter shade on, which will match better. If it doesn't look good, you know what you do? You scoop it off, you put another color on. You put it on, you cure it, and it doesn't look good, you grind it off, you put another color on. It's not that difficult. You've been doing white for so long, pink is really easy. And you use just the usual tools that you like to utilize. So obviously a flat plastic, you get nice stippling using just your little brush that you use for, acid etching. And to get the margins real nice, I invariably use just a tiny little explorer. Backfill this because you want it flat. So any voids, you just ensure they're completely flat at all points. Cure it. It'll just lean on that tissue. And then take off all the excess very quickly so that the flash is done. And then you can get it back in. And this is your provisional in place. It's a provisional cold cure acrylic with composite gingiva. And you get a pink-to-pink mucosal interface up underneath the lip where it doesn't matter. Doesn't match, but it doesn't matter. So that's your provisional restoration, down a couple of weeks, acrylic and composite. And the key to this, of course, is you get optimal tooth form and you hide that interface so crucially. This interface is all pre-planned. Don't find out about it after the fact. This is what she looks like at 3 months. You can see they're getting a little bit yellow because that's kind of typical of biscril. And this was made up quickly in biscril. What else do you see? What can you see that's kind of cool? Look where she smiles to. This lady can smile. You give her teeth, you give her a certain comfort level back, she begins to feel good about herself. She smiles all the way up to here. You remember? I was asking her to smile, didn't see anything. I said, grimace, show me how far your lip can go up when you're really trying. It's not a smile, it's a grimace. And I want to measure how far that is from the incisal edge, because I'm going to ensure the head of the fixture is beyond that. And we just made it, because she got kind of enthusiastic. We go to the lab phase, it's real easy. You've got your models, you get your wax up, real easy. You fill your Siltec with wax on top of the analogs, and then we make the metal. This is ceramo metal, large cut back, so we can make for pretty teeth. And we do white and pink ceramic, flat gingival interfaces everywhere. Anywhere I see a bubble, I just use a CO2 laser and make it smooth as I possibly can, because I want flat interfaces for hygiene. So when you're looking at it and you get this little piece of lip, what you want to do is just blend it in to it's a flat butt joint. It's a butt joint, not an ovate pontic like we taught you years ago. That way we can clean it. And this is what it looks like. Optimal white tooth form, facilitated by pink ceramics. And the pink ceramics we don't have to worry about because it's up underneath the lip. I think it's key to understand that this is not necessarily the best way of doing things. It's a way of handling things. It shouldn't be considered a last resort when all else fails and you've done 12 surgeries, but it should be pre-planned, definitively decided upon treatment plan. This is actually a quote from Urs Belser and Velati, and you'll see he talks about implant-supported fixed prosthesis with integrated artificial gingiva in the aesthetic zone, and they refer to it as the pink power concept. Why? Because it gives you a certain amount of liberation to work for optimal ceramics, not confined by the usual structures. It gives you opportunity. The big deal is learning about the pink-to-pink interface. That's your last interface. Remember, big smile in temporaries. This is a very demure smile, kind of looking over you. She's sipping on a glass of wine, and you just pick up the illusion of reality in these tiny little papilla tips. They're crucial. That's what makes it look real. Or you have, a little more smile. Those little pieces of pink are the name of the game. They facilitate the white incredibly effectively. You can see that we came out very much the way she was when she first started. I'll take you through two last ones. I slipped through this. This is a lady who's already got a bridge in. She's diabetic. She's allergic to everything under the sun. She's medically compromised, and she's got a bridge that doesn't look so good. You can see it's canted down on this side, it runs up on this side. She's missing large chunks of pink, and someone's put some sort of pink on that doesn't really jive very well. So we make porcelain teeth. This is white ceramics that matches her remaining teeth, but look at the aberrant tooth forms that you're talking about. Really ugly. So you've done pretty ceramics, but to make them look good, you've got to add pink. This is adding pink acrylic in the temporary, and then we plan adding the white exactly the way you see. This happens to be a lady who couldn't go through implants, so we're doing it on gold telescopes with a ceramo-metal splint on top that will house it all. Putting it all in and teaching them how to clean, that's totally crucial in the whole process. And that's what she looks like when we complete the case. It's a case, it's an alternative case. It comes with limitations that I had to come up with solutions for. And this is what she looks like. So let's look at the last one, and let's look at all the critical interfaces. Sorry, two more of what you can do. A lady who's got a couple of implant-supported bridges, but they don't look like teeth. They look like piano keys. We do ceramics, we wax up onto it to create the illusion of normal teeth, and we go ahead and add porcelain, and you see you get quite a different look. You want teeth like this, or would you prefer teeth like this? They're actually bigger teeth, brought forward, and you're not hiding them. And you get some illusion of normalcy, naturality. So, in conclusion, let's look at this case. A lady who has unilateral periodontal compromise. You can see it goes down to the root apices. She has very severe type 3 vertical defects, and you're looking at all of this, and you don't even realize just how much is missing in the pupillar area. Large chunks. You start to look at the CAT scans, as Coney alluded to. I mean, we can't manage without CAT scans. You see that she really has no buccal plate. She has no interproximal bone all the way up. So the question becomes, she's a young lady, can we make the left side look like her right side? How best do we go about it? Do we go through the process? We reconstruct it surgically? Or do we do it right from the outset and plan it prosthetically? And the answer to that is cost, time, predictability, the patient's needs. There is no better way. There is no panacea in how to handle this. So the first thing we do is we wax up, and as we wax up, you can see this doesn't look like a lateral. Look at this lateral, even trying to make it look normal compared to that lateral. Look at the squareness of these teeth. Even with, different colored waxes, they don't look like teeth. So the white wax up shows us aberrant tooth form. We add pink so we can now simulate the teeth on the other side. So it gives us our outline, our silhouette form, and also gives us exact dimensions of what Maurice or I would have to recreate in hard or soft tissue. And then the question becomes, can you do it? Can you do it with predictability in how many procedures? And when you talk about predictability, can you do this? Not can you get a papilla, but can you get a papilla that ends up right there and there? So we decided on this case, we're not going to approach it that way. These are the extractions. You look at it, and you can see really a large amount of defect. Type 3, not great for growing bone. We're going to place fixtures in the remaining bone, and we get them placed way, way apically. How far apically? Beyond the inferior border of the upper lip. Added bone where? Purely horizontally. You're getting bone augmentation horizontally, which is predictable. We add soft tissue. This is what she looked like. This is in the Essex. 7 days, 3 months, 4 months. 4 months, you look at it, you're getting a little worried, but it's great. Second stage uncovering, we get a nice, hard, firm base down. And what you're seeing now is a very flat ridge form. Flat, flat, flat. We're going to make it flatter yet. And you see there's no curvature to it. And we've done buccal augmentation to it. It's flat and built out horizontally into the buccal vestibule. So you get a sense of how much it's come out, rounding out the arch form so that we can put teeth where they belong. And the head of these fixtures is where? Beyond the upper lip. This is what model looks like. Acrylic with composite tempering. This interface goes beyond the upper lip. And this is what it looks like tried in. 3-unit, whiten, pink, acrylic basically, screw retained. And this is how she looks, kind of simulating that side. Now we're going to go and look at it in a more permanent, durable material. Go and read the article that we wrote with Marcelo, Christian, and Guy. And you can see we replicate the temperi in the final. And this happens to be zirconium, which is up for another discussion, with some porcelain added to it. Look at what the tissue looks like. deliberately. Trying in the reduced CAD-CAM zirconium framework, we take tooth color, and then you take pink color. And we build it out horizontally. And now you have a screw-retained zirconium prosthesis. And you can see what it looks like and how well it integrates, because this is the inferior board of the upper lip taken into account right at the outset. It must have flat, cleansable ridge contours. You must create them so that they can be maintained over the long haul. This interface is the interface that goes up underneath there. And that's what the final case looks like. So what do you think bothers her? At this phase, when everything else has been fixed up pretty effectively, what is she seeing? She's seeing only this. It never existed before, but all of a sudden it's smack in the middle of her face. You've all had that. So how do you fix it? I mean, what exactly do you look at? Looking at your prosthesis, looks great here, it doesn't look great there. That's what drives her mad. So your options are what? I mean, the first is obviously orthodontics erupt one of them, bring the papilla down, crown it, and you got it made. That's the one. The second is, bond them or do veneers with long white contacts. And the last is restorative pink. How exactly do you do restorative pink? Pink composite, you bind half of it onto this tooth and half onto the other, and you floss down the middle of the papilla. Kind of difficult. So this is what we chose to do. We used Emax. We made it in white Emax. We colored it with pink Emax. We etched the Emax, and we used it as a papilla veneer, bonded to enamel. Here's your papilla veneer. You see it stretches from there in white, and then we added pink. Not completely all the way down, leaving a little void. So this tooth got fattened, gave us strength, gave us bonding area down this whole area. Then we added pink on the outside, Emax. This side gets bonded. She flosses up there, over the top, cleans it, and comes down again. So just a one etched surface. Trying it in, I lodge it in, keep it in close adaptation, nominal pressure on the remaining tissue, and I use just one of those little wood sticks to do it. We isolate it, we air abrade it, you acid etch exactly the way you do, and the nice thing is what? We're all on enamel. Is this going to stay? It's going to stay, promise you. You're bonding to enamel, it's not going anywhere. Is it going to break? Not likely. It's Emax. Kenny will teach you that. We bond it into position, and this is what it looks like in position. That's what she came from, what we were able to achieve. That's 8 months. This is about 2+ years. This is what she's able to emote like. This is using pink to allow us to develop white ceramics optimally. So when we talk about optimal ceramics, it really has to incorporate two components, both the white and the pink. So I hope I've given you some alternatives today in creating that illusion of reality and different ways one might look at some things.